Hello, everyone. I'm Dr. Lisa Graves, project lead for the AFMC response to the opioid crisis. I want to welcome you to today's presentation, Introduction to Medical Treatment of Opioid Use Disorder, with our presenter, Dr. Jennifer Wyman. At this point, I want to acknowledge the lands on which you are all sitting and that we are currently in the traditional unceded and unsurrendered Algonquin Anishinaabe territory. We also want to make certain that we acknowledge the funding that's been received from Health Canada, Santé Canada for this project, and remind everyone that the views expressed herein do not necessarily represent that of Health Canada. This slide makes clear the disclosures of the planning committee in terms of their potential conflicts of interest, which we have worked very hard and are certain that we have mitigated at this point in time. The disclaimer is attached to remind all of you that that this information is not a substitute for good medical and clinical decision making. There is closed captioning and live transcription to this session. If you need assistance in getting that operating, please let us know. Please enter your questions in the Q&A using the Q&A function on your Zoom toolbar. This session is being recorded and slides and the recording will be posted. Following the presentation, you'll automatically get a link at the end of the presentation to a post-program survey. This program improves based on your feedback, and so we really would appreciate comments of what we're doing right and what we can work on to improve. Certificates will be made available on October 3rd. And we just want to remind you that we have a number of sessions coming up that we think may be of interest to you as well. Having finished with the rather boring introduction of the paperwork, I think going ahead to the exciting part, which is a presentation by Dr. Jennifer Wyman. She's assistant professor in the Department of Family and Community Medicine at the University of Toronto. She's the associate director of substance use service at Women's College Hospital in Toronto. She's a medical educator, and she is a key component lead in the Medify project. I'm very much looking forward to Dr. Wyman's presentation, and I hope you find it as enjoyable as I anticipate that it will be. Over to you, Dr. Wyman.
Thanks so much, Lisa. It said I cannot share while others are, oh, here we go. Okay, great. Thank you for that introduction and the acknowledgement that this project is supported by Health Canada. It's part of the AFMC project. And in terms of my disclosures with respect to grants and research support, I've been part of a grant from CCSA as a study looking at OAT outcomes during COVID, and then have received some funding mostly through the Ministry of Health for my work with Medify in developing the MAC Health opioid clinical primers, the work with AFMC, and then some other projects with the Centre for Effective Practice and the College of Family Physicians here in Ontario. So I have no other conflicts of interest to identify. And I guess, per the introduction and our presentation objectives, I just want to acknowledge where I am sitting and what we won't be covering in this, short 45 to 60-minute session. So we certainly can't do justice to the full scope of understanding either the constructs, the situations in which opioid use sits and opioid use disorder can develop. I can't speak to the full spectrum of care in terms of harm reduction and injectable OAT. So I'm talking about my little piece. And I am sitting here in Ontario, and I recognize that the landscape looks different in different parts of the country around current practices of OAT, specific situations like the prevalence of fentanyl at the moment. But I appreciate everyone making time to be here and to learn a little bit more about OAT and how it may be pertinent to your practices, wherever you're sitting. And I'm thinking about data that was just published by ODPRN, that's the Ontario Drug Policy Research Network, based at St. Mike's here in Ontario, that I think is really important to hold in mind as we go through this talk. And that is that of people who have died from an opioid overdose, 30% had interaction with the healthcare system, whether that was Emerge Hospital, primary care, etc., in the week before their death. 6% of those actually had an interaction with the emergency department, and 50% had some interaction with the healthcare system in the month before they died. And so I think the reason that's important for all of us to hold is that regardless of where we're working, whether we're in an inpatient setting doing GIM and looking after with people who may have complications of opioid use, in the emergency setting with someone who's come in with an overdose, in primary care, in obstetrics, in mental health, we need to really be aware of the important opportunity that we can bring to connect someone to life-saving care and help to make those changes. So just a quick overview of some of the acronyms you may or may not be familiar with. You'll see that in terms of the language that we use, we clearly don't talk about addicts, junkies, clean, dirty. Those are all pejorative terms that contribute to stereotyping, limiting, and are associated with stigma. So we're going to try to be medically accurate, and we actually talk about a substance use disorder and not an addiction as well. And people may have different feelings about some of these terms and words that we probably don't have time to talk about today, but we'd like to stay away from things that are value laden and talk about things that are clinically relevant. So as I already mentioned, I really come to this trying to think about the variety of places where people who use opioids or use substances intersect with the healthcare system. And there actually is quite a bit of literature exploring the experiences of patients with substance use disorders, and particularly people who inject drugs, in interacting with the healthcare system. And unfortunately, so many of those reports are about negative experiences in terms of being judged, ignored, poorly treated. And we can imagine that some of the consequences of those experiences are people choosing not to engage with the system or delaying their engagement to the point where their health conditions have really worsened, people leaving without completing their courses of treatment. And we recognize that those types of medical trauma experienced by people who use drugs are complicated and contributed to by the roles that we as people in the healthcare system play. And so there are lots of things that contribute to the care that we provide that we just need to recognize and begin to address. So lack of understanding about how people use opioids, the spectrum of opioid use from less problematic to higher risk. We may not know about the kinds of treatments and evidence-based treatments that are around or how those can intersect with harm reduction. And historically, care for people with opioid use disorder has really been siloed. As I said, I speak from Toronto, where there's a very robust system of clinics, and people think about methadone clinics as the place to go for care. And there can be a lot of lack of continuity or communication between OAT-focused care and primary care. And then, of course, stigma, social and structural stigma that really, again, sort of compound and contribute to the power dynamics that people experience, social exclusion, the way our systems are set up that operate best for people who have access to IT and to transportation and can take time off work to get to appointments and can meet all of the expectations around traditional care. So holding those things in mind, we just want to make sure that we're on the same page in terms of talking about the criteria for opioid use disorder. And I'll just run through those quickly. And again, I mentioned that there are people who can use opioids in ways that are lower risk and may not meet the criteria for opioid use disorder. But today's talk is focusing on medical treatment for people with OUD. So we can see how when we use these criteria, we sort of count up the number of criteria to determine whether someone has mild, moderate, or severe opioid use disorder, and it's not really related to the amount of substance that they're using per se, as it is to how they're using and the consequences on their health and well-being. Same as with alcohol use disorder, it's really not about how many ounces someone is drinking. So cravings, a lot of time obtaining or using, efforts to cut down or reduce use, using for longer or in larger amounts than planned. Consequences, so whether that's impacting someone's function at work, school, or home, impacting their relationships or causing them to give up other important activities. Using in hazardous situations such as driving or roofing, or using when one knows that you already have a condition that's being exacerbated use, such as endocarditis, for example, or an abscess. And then really important to pause and think about tolerance and withdrawal as criteria for opioid use disorder. Because as you probably all already know, anyone who's using an opioid, even a prescription opioid taken as prescribed, will develop tolerance over time. And as a result, can develop withdrawal if that medication is discontinued abruptly. So tolerance and withdrawal are not considered criteria for an opioid use disorder in the context of someone who is, taking their 6 oxycodone per day for chronic back pain and just runs out of that prescription, not because of aberrant use, but runs out of it perhaps because the prescription wasn't, refilled. There was an error. They couldn't get to the pharmacy. When they develop symptoms such as feeling dysphoric, sweaty, cold, unwell, those don't mean that suddenly they've developed an opioid use disorder. They're physiologic responses to the discontinuation of the substance they're used to having in their system. So a little bit about the connections between chronic pain, mental health, trauma, and opioid use disorder. And I think that those conditions have really been, those overlapping and connections have been under-recognized for a long time, but are important, again, as we think about the people that we're working with, some of the barriers that prevent them in accessing care and the things that we need to consider when offering care. So having chronic pain is associated with more than double the risk of depression, generalized anxiety disorder, and PTSD. And it's not simply that having pain gives rise to depression because of the limitations associated with pain. These are really bi-directional or even more complicated, multi-directional relationships, whereby both having a mental health disorder increases the risk of chronic pain and a substance use disorder, and having chronic pain increases the risk of having a mental health disorder and a substance use disorder. And what's really important to touch on is the very high prevalence of trauma in the lives of people with substance use disorder, so up to 75%. And again, this doesn't mean that 75% of people with substance use disorder have a diagnosis of PTSD, but have experiences of some type of trauma. And when we talk about trauma, we think about sort of the classic definitions around a natural disaster or war. But of course, there are other types of trauma, including medical trauma, intergenerational, and historical trauma. So I certainly can't do justice to the topic in terms of specifically historical trauma and colonialism. But I think it's important to acknowledge that amongst the types of trauma that we typically think of, if we also think about racism and the experiences of people from marginalized communities, whether their identification is BIPOC, LGBTQ plus, etc. There are lots of things that have impacted where people are by the time that we're seeing them, and make it really important that we hold this lens and try our best to practice at least trauma awareness and cultural safety. Again, topics for another session entirely. But certainly many of our patients have experienced adverse childhood experiences. And we know that there is a very strong relationship between the number of ACEs experienced and the likelihood of someone developing a substance use in general, illicit opioid use, and injection drug use, perhaps up to 10 times the risk for someone who didn't have ACEs. And that being exposed to ACEs and living with these, we can imagine, increases the likelihood that someone encounters other situations that are complicated, that create the risks for conditions that lead to chronic pain, that impact their ability to find and access and use resources in some of the ways that other people can. So holding all of that, which could make it sound a little bit, daunting to come up against that, we're going to talk about opioid agonist therapy, which is first-line evidence-based care for OUD. And I'm trying to be careful about using the word care and therapy and not refer to the term treatment all the time. And the reason for that is that historically people have talked about opioid agonist treatment as being consistent with the goals or aligned with the goals of abstinence, and thought about OAT as being for people who want to quit using opioids altogether. And there are many aspects of the program that have encouraged that, such as the focus on abstinence to help achieve take-home doses. And while there is still merit in thinking about abstinence for people who choose that as their goal of therapy, it's really important to remember that opioid agonist therapy has a very important harm reduction role in helping people to reduce the harms associated with risky opioid use, regardless of what their long-term goals are. So there is a strong evidence base overall for OAT. Much of the evidence comes from research on methadone specifically, which has been used for decades. A lot of the research started in the 70s and continues now. But it continues to demonstrate pretty powerfully that being on OAT reduces the risk of overdose at 3 and 12 months of treatment compared to no treatment, detox, residential treatment, naltrexone, or psychosocial supports. And in addition to reducing the risks of overdose, treatment with methadone is associated with a whole host of other improvements in terms of health and the social sphere. So in reductions in illicit opioid use, crime, injection practices, and improved outcomes, including reductions in arrest rates, drug selling, improvements in employment, and family relationships. And as I mentioned, there's current evidence that supports the fact that being on methadone is protective against overdose, even in people who continue to use fentanyl. I referred earlier to that ODPRN study, which showed, not surprisingly, that fentanyl continues to be the overwhelming opioid associated with overdose death. I think in the most recent report, fentanyl was found in 89% of opioid-related overdoses. And people on methadone are among those who may continue to use fentanyl. There are different hypotheses about why methadone is protective. And it may be not only because people who are on methadone use less fentanyl, but it may be also that being on long-term OAT helps to preserve some tolerance to the respiratory depression effects of opioids, so that even when people are using, they're not coming from that sort of opioid naive or lower tolerance place and have some ongoing tolerance that's protective. The other thing I want to draw your attention to is just that comment about in-hospital provision of methadone for people who inject drugs being associated with lower rates of people leaving against medical advice and actually completing their treatment. So, as I mentioned, we're focusing on oral OAT and not the full spectrum from harm reduction and withdrawal management to injectable OAT. I hope that people will, check out all of those other talks. The other thing that I think, so two other things I want to mention, sorry, withdrawal management is on the left side of this slide. But I want to say clearly that CRISM and the 2021 synthesis of Canadian guidelines emphasize that OAT is first line and withdrawal management alone is not recommended as treatment for OUD. And that's because of the high rates of relapse and overdose in people who have been offered withdrawal without long-term supports. Likely related to the loss of tolerance when they're in treatment and then overdose when they go back to using the amounts that they were previously tolerant to. The other thing is that both CRISM and the 2021 synthesis focus on buprenorphine as first-line treatment because of its safety profile relative to methadone, which is very valid and true, but we need to remember that methadone is also first-line treatment and that there are situations where it may be more appropriate than buprenorphine. So we'll talk a little bit about that. And then lastly, that all of this really needs to sit alongside psychosocial supports and harm reduction strategies. And the evidence for OAT is stronger than the evidence for psychosocial supports in terms of impact for people with OUD. But I think any of us working in this space would argue that it's when we combine care, and certainly when we can really truly offer wraparound care that is not just about OAT, but includes care for primary health conditions, medical complications, mental health, that we build the best relationships, which is probably what is really associated with a lot of the best outcomes. So I'll start by talking about buprenorphine, which is a really interesting molecule and works well because it's long-acting, it has a high affinity for the mu opioid receptor while being a partial agonist, and also has a ceiling effect. So these are some of the properties that make it such an important and valuable molecule in OAT. And what you can see in this diagram is what's called the partial agonism. These slides are taken, by the way, from the AFMC modules, which have great graphics, and I hope everyone will get to when they're available. So you can see that the little purple ball, which we could imagine to be morphine, for example, on the right, is a full opioid agonist. It attaches really nicely to that opioid receptor, creating all of the downstream effects in terms of analgesia, dopamine release, and everything else. Buprenorphine schematically is a partial agonist. It doesn't fit quite so well in that receptor. And so what it does is create partial effects. And those partial effects are enough to prevent withdrawal at the right dose, but don't create the full agonist effects, which help to reduce some of the side effects and some of the risks. The high affinity of buprenorphine means that it actually displaces other opioids. So that's important when we first start treatment. We'll talk about that in a minute. But it's also important when people are taking buprenorphine, because the buprenorphine being attached so strongly to those receptors means that if someone uses a full mu agonist at the same time, they have much less response to it, both in terms of, primarily in terms of the euphoria, but also in terms of some of the other opioid activities and pain relief. So it's important when we're thinking about combining opioids to think about those benefits as well. And then in terms of the ceiling effect, this is one of two really important safety issues with buprenorphine. There's a slight sort of lack of correctness. That wasn't the right word, but in this slide, where it says that mean doses above 24 to 32 milligrams do not have additional opioid effects, because there is thinking that above 24 to 32 milligrams, there continues to be an increase in other opioidergic effects, but not in terms of respiratory suppression, which is what's so important with buprenorphine, that it's not as high risk for people who are at risk for respiratory suppression because of COPD, for example, or other sedating medications like benzodiazepines or higher dose gabapentinoids. The other thing that's so important about buprenorphine that's not captured here is the fact that it is not QT prolonging to the extent that methadone is. I keep referring to buprenorphine because that's the active molecule and the active opioid. But in a lot of the literature, you'll see buprenorphine naloxone, and that's because that's how buprenorphine is packaged here in Canada. The naloxone is added to the sublingual tablets specifically to deter people from misusing the tablets by injection. So in the past, I think it's less common now, patients thought that they didn't want to take buprenorphine or Suboxone or sub as they call it, because they heard that the naloxone would put them into overdose. They thought that the naloxone somehow blocked them from getting high. And that's not true. The naloxone is not absorbed. It actually has no effect when the tablets are taken sublingually. So it's not contributing to the effect of the buprenorphine at all. It's simply there to deter people from injecting because it will create almost like a precipitated withdrawal, an naloxone-induced withdrawal if injected. There are people who inject buprenorphine naloxone tablets. It's not particularly common, but it seems to happen more in places where there are fewer other opioids available for use. And although not the topic of today's talk, really useful to know about the extended release options by brand names. And I apologize, Sublocade, which is a monthly injection, and Probufene, which is a 6-month implant. And there's some really interesting work going on around using these as options for people who might be at higher risk for discontinuation of treatment because of difficulty getting to the pharmacy on a regular basis, or people who are stable and simply don't want to come to the pharmacy on a long-term basis, either because of work or travel, or who don't want the ups and downs associated. So as I mentioned, this partial agonist high affinity situation works well for people who are on buprenorphine, but it can create a little bit of a hitch in starting treatment, in that if we give someone buprenorphine while they still have a full mu agonist on board, the buprenorphine attaching to that opioid receptor displaces the full agonist, but doesn't fully replace its activity, resulting in a net opioid deficit. That's what we call precipitated withdrawal. And that feels pretty lousy because it's essentially all of the withdrawal symptoms all at once. So our goal is to avoid that. And this just gives me a little opportunity to review opioid withdrawal symptoms and the COWS scale for those who aren't familiar with it. And I apologize that it's pretty small to read. But a reminder that sweats, restlessness, agitation, arthralgias and myalgias, runny nose, tearing, nausea, vomiting, cramping, diarrhea, shakes, all of these are, and sort of the goosebumps, the chills that people feel are all really uncomfortable. And if someone has experienced precipitated withdrawal, they're pretty unlikely to want to retry buprenorphine. That's one of the things that we sometimes run into if people have tried a tablet from someone on the street and not known how to start it appropriately. They may think that they're allergic to it or it doesn't work for them because they experienced that reaction unbeknownst to them. So there are a couple of ways that we try to get around that. And I'll talk about the traditional start first. So that really involves making sure that someone is in sufficient withdrawal, so COWS of at least 13, and that enough time has passed since last use of the opioid, that opioid is not floating around, you can imagine, not attached to those receptors to the same extent, so that the buprenorphine can attach without displacing and just basically do its job overall. And through the literature, various guidelines, people have come to sort of these approximations, again, using clinical judgment, looking at withdrawal, looking at the other things around how people clear their medications. But in general, if you wait 12 hours from short-acting opioid use, like an oxycodone, for example, or short-acting morphine, or more than 18 hours from an IR or CR preparation, you'll have both sufficient withdrawal and the right amount of time to avoid precipitated withdrawal. It's a bit more complicated with fentanyl. Fentanyl itself is not a long-acting opioid, but when people use fentanyl over time, because it's fat soluble, it's released gradually. And so we've seen reports of people experiencing precipitated withdrawal when starting buprenorphine well beyond 24 hours from last use. And so there's some, I guess, lack of clarity or agreement about when you can safely start buprenorphine, which is why we'll talk about other options in a moment. I favor definitely more than 24 and closer to 48 hours. And with a very long-acting opioid like methadone, you really need to wait 72 hours. And so that, again, is a role for these alternative approaches called microdosing. So essentially with a traditional start, when you had someone who was in withdrawal, whether they were in the emergency department, clinic, or hospital, you could just give them their first dose, monitor, and continue. And starting someone at home is really a version of the same thing that we'll talk about in a moment. The usual first dose in that kind of setting would be 4 milligrams of buprenorphine or 2 milligram tablets. A reminder that these tablets have to be taken sublingually. If they are swallowed, they're inactive because of first pass effect. So the medication has to really sit in the mouth under the tongue. And we advise people not to eat, drink, or talk for the 10 to 15 minutes that takes. We recommend a 2 milligram dose in an elderly patient, someone on benzodiazepines, or who has other risks of sedation. And then essentially, we like to reassess them around an hour. In the emergency department, if you can see someone after an hour and you know that they're not worse, so they haven't experienced precipitated withdrawal, you could give them another dose and discharge them with tablets or a prescription to complete the rest of their dosing at home. In the clinic setting, the same thing. When I first trained, we asked people to sit around or come back at 2 to 4 hours so that we could reassess them and give them another dose. I no longer do that. I accept the fact that that's a real sort of inconvenience for people. Waiting rooms are not a comfortable place to sit. And certainly for the last 22 months, we've been avoiding having people sit around in waiting rooms or come back for, in-person care that they don't need. So you can do a follow-up with a phone call, with a video visit, either later the same day or the next day to see how they did, and instructions to complete their first day of dosing for 12 to 16 milligrams, depending on what you know about their the extent of their substance use, their tolerance, and any other conditions. And then usually we would ask to see people back within 3 to 5 days, but a maximum of 7 days is probably acceptable too. Again, especially if you can have some kind of contact virtually to follow up on them. So what about for people who are, reluctant to come in, for example, in withdrawal, don't want to be in your waiting room in withdrawal, or someone who comes into the emergency department who really wants to start treatment, but, there just hasn't been enough time passed and they're not in sufficient withdrawal yet? Well, that's when there's a role for the home start. So it uses the same principles in terms of waiting for the right amount of time and for at least moderate withdrawal, but it gives people the tablets to initiate on their own. And instead of using the COWS or the SOWS, which is the subjective opioid withdrawal scale, we created this other way of measuring withdrawal symptoms, which basically maps onto the SOWS. And using this, we've never found that people have experienced precipitated withdrawal when they've really followed these instructions. I want to give credit. This original approach came from Lakeridge Health in Oshawa, Ontario, where they developed the initial graphics that we've modified. I'll also acknowledge this is a patient handout, and that's why it says Suboxone and not buprenorphine naloxone, because patients are much more familiar with the term Suboxone. And this handout is something that you can give to someone to identify when they're ready to start treatment, instruct them specifically about their starting dose in terms of milligrams and also tablets, being specific about what their maximum number of milligrams and tablets would be for the day, whether it's 8, 12, or 16, and allowing them to track their dosing so that you can review it with them when you follow up. And this graphic is found on the Medify website as part of our ED toolkit, which we can talk about a little bit if that's helpful. Microdosing is what I refer to as alternative treatment. So whether you're starting someone in an observed setting or at home, again, remember, that requires someone to be a minimum of 12 and potentially more than 24 hours from last opioid use in order to avoid precipitated withdrawal. Microdosing takes the completely opposite perspective, and what it does um, is suggest that when you start buprenorphine at very low doses, so 0.25 to zero point 0.5 of a milligram, which is an eighth or a quarter of a tablet, the dose is so low that the buprenorphine doesn't displace the full mu agonist. It really just kind of sits alongside it. And that as you increase the amount of buprenorphine incrementally, it sort of cohabits with the other opioids. And then once you get to a dose above 4 milligrams, there's enough buprenorphine on board that you can increase the dose quite rapidly, again, without creating precipitated withdrawal. And this was based on the work of Robert Hamig in Switzerland and has been repeated. There's no approved guideline because there are a number of different versions of microdosing done both in hospital and in community practice, but there is now quite a substantial body of case reports in the community of practice. And it's been really helpful, particularly in a couple of settings, I would say. So in our patients who have chronic pain and are on prescription opioids, but would benefit from transition to buprenorphine because of its safety profile, for example, microdosing has been really useful. In patients who are on methadone, who want to make the switch to buprenorphine, tapering down to 30 milligrams and then needing to be off methadone for 3 days is not an experience that most people will endure. So buprenorphine has been very helpful in that situation, up to quite high doses of methadone, like 80 to 100. And then in patients who are using street opioids right now because of the amount of fentanyl, as we alluded to. So starting buprenorphine at these low doses is not something that's going to help them feel better immediately, but rather they can initiate the buprenorphine and start building it up in their system, even if they're still using. And then once you get to 4 milligrams, you can increase quite a bit more rapidly, trying to get to the point where they're actually getting benefit. So again, what we really want to think about is what can we offer that's not just sending someone home saying, sorry, you're not in withdrawal. I don't have anything that I can give you. And this may be a little bit difficult to read. Again, the sample of the prescription comes from the ED toolkit on the Medify website. And it's an example of a prescription that could be used as a template in any kind of setting. Microdosing is done, again, as I mentioned, there's no one guideline, but there are sort of accepted once daily and twice daily versions. The sample prescription shared here is a BID dosing formulation because it helps people get to a higher dose at the end of a single week to 12 milligrams rather than being on just 4 milligrams by the end of a week. And at 12 milligrams, there's enough buprenorphine that people might actually begin to appreciate the benefit, whereas they're not going to have that at 4, 6, or 8 for people who are using fentanyl these days, different with the pharmaceutical opioids. And these are links to some more information, again, on the Medify website about options for how to then either taper people who are on short or long-acting opioids or move forward in terms of the dosing. Once we have someone on buprenorphine, of course, the goal of care is to get them to a dose where they feel just pretty level for 24 hours. So not feeling sedated, not having withdrawal, and not having cravings. And that's our goal with all OAT, basically. And that's a conversation. It's really an ongoing conversation with people that we're seeing around how they're feeling physically, but also how they're feeling psychologically in terms of cravings. In the past, I think my training was only to increase someone's dose if they had observable or clearly describable physical withdrawal symptoms. And I would argue now that that's probably inadequate treatment. The cravings can really, regardless of whether there are physical symptoms, can drive people to use, and we need to really be aware of those as well. And then lots of things that we don't have time to chat about today in terms of BID or TID dosing for pain, which can be really effective. Just want to mention that buprenorphine is safe in pregnancy, but we don't want to put someone into withdrawal in pregnancy. And so if they were already in withdrawal when we saw them, it would be appropriate to start buprenorphine, or microdosing would be an alternative. as would methadone, obviously. And a really important piece in terms of patients who end up in hospital for other reasons, buprenorphine does not need to be stopped for surgery, for general anesthetic, or for treatment of perioperative care. In fact, if we stop buprenorphine, then we put people in a situation where we have to restart it all over again, and that actually puts them at risk. So we can either continue the doses or reduce them slightly. There's no clear evidence that that's necessary, but I know that's within the comfort zone for some people. But as long as we maintain some buprenorphine on board, then someone doesn't have to restart. They can just increase their dose again when they're off the other medications or being discharged. So methadone in a few minutes. Methadone may be preferable to buprenorphine for people who've been on it in the past and did well on it. People who don't want buprenorphine, who didn't tolerate it, who didn't have a good experience with it, who've been on buprenorphine and just, were not successful with it. And the reason I say people at high risk of treatment dropout is because the studies on treatment retention show that there are higher rates of treatment dropout or better rates of treatment retention for people on methadone than people on buprenorphine. And the other thing that's being talked about a lot is whether buprenorphine as a partial agonist is really powerful enough to mitigate the high tolerance of people using street fentanyl these days. And methadone just may be able to reach that more effectively. So it's a full mu receptor agonist, long-acting with a long half-life, and it has some significant risks in terms of respiratory suppression, that long half-life being a risk if the dose is increased too rapidly or is too high relative to someone's tolerance. And of course, it's QT prolonging. It's typically dispensed in liquid form mixed with juice to deter injection. And again, I know that there are different sort of modes of practice across the country, but certainly here in Ontario, to a large extent, methadone management and methadone care was offered in sort of standalone clinics, often clinics that were attached to or affiliated with a pharmacy for convenience for the patient, really, but also set up to help with monitoring including urine drug testing. And one of the reasons that methadone care was so focused was that there were a lot of hoops to jump through, even as a provider, let alone a patient, requiring a Health Canada exemption and particular training. So Health Canada has lifted the exemption or the requirement for an exemption in order to prescribe methadone, but specific training courses are still recommended because there are fine points associated with these risks of methadone management and monitoring. And I know I'm not doing justice to all of them, but I want to give an overview, and I'm happy to talk about, to answer questions or respond to comments in our last few minutes. So because of its long duration of effect and its respiratory suppression, we need to be cautious using methadone in people who use alcohol, benzodiazepines, or other sedating medications. And I specifically identified gabapentin and pregabalin because of recent literature showing that at higher doses, those are as risky as benzodiazepines, potentially, with high-dose opioids, not only methadone, but other opioids prescribed for pain as well. People with severe sleep apnea or COPD, people with advanced liver disease because of clearance of methadone, and co-prescription with other QT prolonging medications. So because of these risks, historically, methadone guidelines recommended starting at low doses and increasing doses quite conservatively, between 5 or 15 milligrams for people with low opioid tolerance. And most providers, I would say probably, initiated prescriptions between 15 and 25 milligrams. Nobody ever wanted to be at the highest dose, right, at the 30 milligram as a starting prescriber. And dose increases are typically made every 3 to 5 days. In increments of 5 to 10 milligrams. That 3 to 5 days is really critical with methadone, whereas buprenorphine doses can actually be increased daily. Because of the very long half-life of methadone, the effects are actually still building over 2 to 3 days. And if we increase the dose too rapidly, we really do risk getting into that respiratory suppression and overdose that we worry about. But here we are in the age of fentanyl, and what people tell us is that 20 milligrams doesn't touch them. and that even 60 or 80 is not really impactful, and that higher doses, often above 80, 100, or even higher, are necessary for people to start feeling any benefit. And the reason it's so important for people to feel the benefit of methadone is that if they don't, and it's easier to continue using fentanyl than make it to the clinic every day to keep dosing and work their way up, then we're not really protecting them from overdose. And so a group of us in Ontario and affiliated with Medify created a guideline last year that tried to address this issue. And so it's pushing boundaries, but in ways that we feel are evidence-based in terms of looking at starting doses and dose increases over time. Again, we can't delve into it too deeply, but to say that we recommended starting methadone at 30 milligrams, even if benzodiazepines are present on the urine drug screen. And that's because basically anyone who's using street fentanyl is being exposed to benzodiazepines and benzodiazepine analogs in the fentanyl. And so if the goal is to increase the dose efficiently, safely, but efficiently, then if we start at a higher dose and increase by higher increments, of course, monitoring and considering other risks for toxicity, then we can achieve a daily methadone dose of 75 milligrams, inside 2 weeks, which is much more likely, we believe, not evidence-based yet, to help people feel committed to continuing their treatment. We think it's really important that physicians practicing in a hospital setting be prepared to initiate OAT to help reduce rates of patients leaving AMA and to complete their treatment courses. It's not necessary to have an addictions consult service. A physician could prescribe 10 or 20 or 30 milligrams of methadone, especially in the hospital setting where someone is being observed for sedation and their O2 sats can be monitored. If there are concerns, then lower doses could be started. We would still recommend following the usual course in terms of dose increases being not more than every 3 to 5 days. And then just briefly to say that slow release oral morphine or Cadian is an important third line consideration for people who, again, have not been successful or have not tolerated buprenorphine or methadone. There are some situations where it's actually being combined with methadone, particularly in terms of getting people started on treatment and trying to, again, provide coverage of those withdrawal symptoms. We really draw on the BCCSU guideline. I think that's the only Canadian guideline on SROM currently. Starting doses can be between 30 and 200 milligrams and increased again by sort of 30 or 50 to 200 milligrams, depending on what you're hearing from the patient about what they're using and what you've observed in terms of their tolerance. Doses can be increased every 48 hours, but they also need to be reduced if someone has missed more than 2 doses in a row. So to wrap up really quickly, for OAT to work and help engage people, retain people in care, to reduce the risks of overdose and help them achieve their own goals, we really need care that is patient-centered and not physician-centered. And that involves considering all aspects of care above and beyond the dose, around how we can extend rather than canceling prescriptions, how we can be flexible around clinical assessments and use virtual tools, not requiring people to come in person all the time, how we can recognize and address issues around stigma, and one really important piece is how we can include peers and navigators in program design and development and evaluation and support. And I think I've really tried to emphasize this, but I hope enough to suggest again that I think OAT is really a vital but just singular aspect of care, and that we really need to focus on the whole person, on their goals, and helping them to meet those goals. So there are some resources that are linked here. As I said, I'm happy to answer questions, happy to provide links to others, but it is really exciting that there are communities of practice that are developing across the country. I'm sure I've not captured them all with my Ontario lens. New forums like this in order to really talk at a national scale about our practices and share best practices, and this burgeoning movement of rapid access clinics, which is really exciting. So thank you. Okay, I'm trying to take a quick look at the chat. I'm happy for my slides to be shared. Great. I don't know when they were last. I made a couple of quick revisions this morning, so the most current version is fair. I see a question. In Quebec, we start often at 40 milligrams. I wouldn't say that that's necessarily too high. No, certainly not if that's what you're doing and you've been successful with it. Um, we looked at a number of different guidelines, including European and ASAM guidelines. And there are some that recommend starting at 40 milligrams. But what we found was that in those protocols, the dose increases were actually a little bit smaller. And so at the end of a 10 to 14 day period, the 40 milligram starts that we learned about through our literature searches and the 30 milligram with 15 milligram increases ended up being around the same place. And we just felt that there was more literature to support 30 milligrams as an initial starting dose. But I would love to see more about what you're doing as we look at revising these guidelines going forward. I also want to say that when we developed that guideline document, we were a group of physicians and we shared it subsequently with a focus group of people with lived and living expertise. We realized in retrospect that what we need to do in terms of looking at any of these guideline projects is involve people with lived experience from the get-go. But certainly what we heard from people was that 40 milligrams for people who were using in serious ways would not overdose them, would not touch them. Many people had experience with, being methadone naive, but taking 60 milligrams, for example, and not experiencing any undue sedation at all. So I'm really interested in the fact that you're doing that. And I think we have a lot to learn from you. Are there particular courses for providers looking for more information around caring for people who use drugs? That's a great question, Laura. I think what you're maybe referring to is sort of patient-centered care, working with peers, or holistic care. I think my short answer is no. I think that, there are various conferences here in Ontario. The CAMH conference, the Medify conference, I think tries to identify those things. The MAC Health opioid clinical primers that are on my last slide in terms of resources address caring for people who use drugs, but also caring for people with chronic pain and that overlap. And there are 2 modules there that address non-pharmacologic treatments for chronic pain. And again, that sort of intersection of mental health and trying to look at both pharmacologic and non-pharmacologic issues there. But I think you've raised an important area that is a gap. Either it's a gap in my knowledge or it's a gap in what exists overall. Side effects of buprenorphine. As with any opioids, even though it's a partial agonist, constipation, sweats, although lower risk than with other opioids overall, sometimes headaches. The main things with buprenorphine, I would say, have to do with its mode of ingestion. So because it has to sit in the mouth for absorption, some people find that they really get nauseated with it. Some people don't like the taste. They find that really irritating. I definitely hear about headaches more with buprenorphine than with other OAT. All opioids can cause dryness of the mouth. I think there's ongoing discussion about why people on methadone in particular seem to have issues with their oral health. And it was thought that buprenorphine might get around that. But I actually have seen people saying that they felt that because of the way it needs to sit in the mouth and can sort of get into the teeth, that it can be really, they've observed, this is anecdotal, that it's been an issue in terms of their oral health as well. There is a new formulation. It's a buprenorphine film. It comes in the same combination strengths as the buprenorphine sublingual tablets, but it adheres to the buccal mucosa or the sublingual mucosa very rapidly, and it may be a little bit better in that respect. I don't think it's covered on most provincial drug formularies, so it would probably be pricey if someone didn't have private insurance for it. But it's another another option. So other than that, I think the reasons that it might not be tolerated would be just if it weren't effective enough for somebody, if it weren't covering their withdrawal symptoms fully. And then an interesting kind of sidebar is that some people who use buprenorphine still want to get high. And, we've talked about using OAT in a model that includes both abstinence and opioid use as within, reasonable goals for people. So again, because of that really high affinity to the receptor, what people will report is that they just don't get that same euphoric response if they use. And so for some people, I haven't heard that a lot, but for some people, that may be something that they don't like about it. They feel like it's blocking the high. And that may be a reason that they're not happy with it.
There are also some questions in the Q&A box.
Oh,
I can read them out, no worries. So one of the first questions is, why does it need to be taken SL? I believe this is in reference to initiating buprenorphine treatment, and they're asking about first hepatic passage.
Yeah, so first pass effect. So it has no effect when it makes it through the stomach and absorption. It's inactive, so it needs to get right into the bloodstream. High dose buprenorphine naloxone defined as greater than 40 milligrams. I don't have experience using buprenorphine at anything higher than 32 milligrams a day. I think that although there may be some ongoing benefit, we said that there's not a ceiling effect necessarily at 32. My experience is that if someone hasn't achieved good results at 32, they're probably just not going to. But given its safety, if someone were doing well and you thought that maybe tweaking a little bit more would be more helpful, that would be feasible. I have heard, and I can't substantiate this with a specific reference, that at doses above 32 to 40 milligrams, there actually may be some spillover naloxone absorption, even though I said that there is no naloxone absorption in the sublingual route. I've heard people say that at those very high doses, there's just enough that there may actually be. So I probably wouldn't go higher than 40, suggested as a trial. And if it were effective with documenting, all of the reasons that you were sort of going above the recommended levels, continue. But if it's not effective, then reduce back to what would be considered standard care. And then the last question I see is about methadone take-home doses. I could spend an entire hour talking about this. Yes, there was an increase in take-home doses in Ontario during the pandemic. That's not just anecdotal. There are a couple of studies, one that was a survey of providers and patients, that's actually just being published, and then an ODPRN study looking at ICES data. So for those not in Ontario, ICES is the Institute for Clinical and Evaluative Sciences, and they can look at take-home doses from the narcotic monitoring system and see how many people had take-home doses and how those things shifted. So there was a significant increase in the first part of the pandemic. It decreased again by about August or September of 2020. And then we're looking at what's continuing to happen since then. And again, the very short answer in terms of reassuring news is that there does not seem to be any increase in harms associated with increased take-home doses in terms of emergency department visits, hospitalizations, and overdoses. And from our surveys, it appears that that increase in flexibility around take-home doses was really appreciated by people. They felt that it improved their ability to communicate with their providers and the relationships overall. Some people chose to return to pre-pandemic take-home doses. Others, were really keen to keep them going. I think it depended on the number of take-home doses that people had. But personally, I hope that it will give rise to a more sort of patient-centered clinical judgment approach to take-home doses, looking at ability to store safely and the level of risk rather than the sort of algorithms that we were bound by in the past. Well, that took us right to 12:59. I'm happy to stay on if anyone has other questions or comments. I really appreciate those that have come up so far.
And just as we come up to the end of our official time together, our thanks to Dr. Wyman for a wonderful presentation, and to all of you for engaging and participating and asking questions and becoming part of this national discussion about how we are responding to the current challenges with opioids. As you close out the meeting, you'll see the survey. Again, we really appreciate your feedback. And again, my thanks to Dr. Wyman for the presentation today.
My pleasure. Thanks, everyone. Have a great day.